In the high-stakes world of emergency medicine, every second counts. Today, we explore the critical battle against congestive heart failure, a challenge that tests the mettle of every emergency physician. Welcome to our cinematic guide on the clinical features, diagnosis, and treatment strategies for CHF, tailored for the heroes in the ED. Our story begins with recognizing the enemy, congestive heart failure. The clinical stage is set by a host of telltale signs and symptoms. In the spotlight of the emergency room, you encounter dyspnea, acute, sudden shortness of breath that hits both at rest and during exertion. Often coupled with orthopnea or the notorious paroxysmal nocturnal dyspnea, where the patient wakes gasping in the middle of the night. Fatigue and weakness, these aren't just tired feelings, they're the echoes of a heart that's struggling to pump with enough force. Peripheral edema, observe the subtle yet dangerous swelling of ankles, legs, and even the abdomen, a stark visual of fluid overload. On physical examination, listen to the whispers of the failing heart. Lung examination, bibasilar crackles, an audible sign of pulmonary edema. Cardiac examination, an S3 gallop, sometimes called the Kentucky gallop, signaling the heart's desperate attempt to compensate. Accompanied by tachycardia and potential arrhythmias, jugular venous distension, hepatojugular reflux, visual markers of increased central venous pressure, and a failing pump. In the ED, remember, a combination of respiratory distress, a symphony of RALs, and signs like JVD and edema are your red flags, especially in patients with underlying cardiac histories. With the initial assessment complete, the RAL investigation begins, determining the root of the crisis with precision and speed. Begin with rapid vital signs assessment. Blood pressure, heart rate, respiratory rate, and oxygen saturation are your first clues. Dive into the patient's history, previous cardiac events, medication adherence, and recent triggers such as infections or arrhythmias. Key to your diagnosis is the measurement of BNP or NT-proBNP levels. Elevated levels confirm the suspicion of CHF over other respiratory causes. Don't forget, check cardiac enzymes to exclude myocardial infarction, and always monitor electrolytes and renal function before setting off on a course of diuretics. For a deeper dive into the patient's respiratory status, an arterial blood gas, ABG, can provide critical insights into oxygenation and acid-base balance. Your eyes in the sky, the chest X-ray. Look for the classic signs: pulmonary congestion, curly B lines, an enlarged heart, and even pleural effusions. Complement this with point-of-care ultrasound. POCUS watch for B lines that signal interstitial edema, and assess the heart structure and function right at the bedside. A must for revealing arrhythmias, ischemic insults, or conduction abnormalities that might be the sparks igniting the crisis. In the arena of diagnosis, combine history, physical exam, critical labs, especially BNP, and rapid imaging for a swift and precise identification of your patient's condition. Now, the moment of truth. Treatment. In the war against CHF, decisive and immediate action is paramount. Initial stabilization. Start with oxygen therapy. Administer supplemental oxygen to keep SpO above 92%. In cases of acute pulmonary edema, consider non-invasive positive pressure ventilation, NIPPV, with CPAP or BiPAP. Your mission is to keep the oxygen flowing and the patient stabilized. Diuretics. The first line of attack, IV loop diuretics, such as furosemide, are your frontline soldiers. For diuretic-naive patients or those in initial presentation, administer 20 to 40 milligrams IV bolus. If the patient is already on chronic diuretics, double the usual IV dose. Repeat dosing every 1 to 2 hours may be necessary. carefully guided by the patient's urine output and overall clinical response. Constant vigilance is key. Monitor renal function and electrolytes, particularly potassium, vasodilators, relieving the pressure. Nitroglycerine enters the fray as a potent vasodilator. Begin with sublingual administration, if warranted. Ramp up to an IV infusion. For IV dosing, initiate at 5 to 10 micrograms a minute. Adjust the infusion rate to reduce preload and afterload effectively. Always staying alert to avoid hypertension. Remember, avoid nitroglycerine in patients with low systolic blood pressures, SBP less than 90 mm of mercury, or those with right ventricular infarction. Additional considerations. Once upon a time, morphine was a trusted ally for relieving dyspnea and reducing preload. Today, its role is controversial due to risks of respiratory depression. It's reserved for only the most severe cases, and with strict monitoring, in cases where the heart's pump is failing to deliver, coupled with hypertension, inotropes like dobutamine can be deployed. However, these are typically reserved for refractory situations and require expert cardiology consultation. Never forget, the underlying causes of this crisis, be it ischemia, arrhythmia, or infection, must be rapidly identified and managed to achieve victory. Monitoring and ongoing support. Constant reassessment is your mantra. Monitor vital signs, oxygen levels, and urine output. For those with severe, refractory symptoms, consider an ICU admission for the critical support they need. In this decisive moment, remember rapid stabilization with oxygen and NIPPV, quick initiation of furosemide, and judicious use of nitroglycerine are your keys to turning the tide against CHF. In the emergency department, every heartbeat counts, every second is a victory over time. Armed with rapid recognition, precise diagnostic tools, and powerful treatment strategies, you are the frontline warrior against congestive heart failure. This is not just medicine, it's a battle for life. Stay sharp, stay resilient, and let nothing stand in the way of delivering life-saving care. Thank you for joining us on this cinematic journey through the critical management of CHF. If you found this guide enlightening, hit that like button, subscribe for more high-impact medical tutorials, and share with your colleagues. Together, we can make a difference, one heartbeat at a time.